I am now pleased to introduce our first speaker, Dr. David Grabowski, a professor of healthcare policy in the Department of Healthcare Policy at Harvard Medical School. His research examines the economics of aging with a particular interest in the areas of long-term care and post-acute care. We're so grateful to have him with us today to share his research and perspective. David?
Great, thank you, Catherine. It's really nice to be here with everyone, and thanks to the NIHCM team for including me today. So I want to speak directly. We have a broad topic today of meeting the healthcare needs of an aging population. I really want to drill down and think about how we can meet their long-term care needs. Let me start with just some data at a high level. We spend a lot of money in the US on long-term care services. And you can see there, these are data from Kaiser. We spend over $400 billion annually on long-term care services. Most of that goes to where individuals want those services, in the home and the community. And you can see there in purple, most of those dollars are public dollars. They come from Medicaid. However, when you stack up the US against other countries, we don't look so great. We actually lag behind a lot of other countries in terms of public spending. Now, this isn't overall spending, but you can see if you look down quite a ways on this list, usually the US, when it's healthcare spending, we're at the very top. Here, we're not an outlier, we're an inlier right there between Portugal and Israel. It's really countries in Northern Europe that are spending a lot of the dollars on long-term care. What we ultimately do is place a lot of this burden on families spending out of pocket. And we know these services are not cheap. And you can see here, these are once again data from Kaiser. You can see the median income for a Medicare beneficiary. It doesn't take long, as many of us know from our own families, whether it's assisted living, home health care, nursing home care, you very quickly spend out your savings and end up qualifying for Medicaid. How do we make this work in the US if we largely have Medicaid and then we have some out of pocket? We do this on the backs of families. And these are some data from the Society of Actuaries, where you can see up at the top there, we spend over $4 trillion in the US on healthcare, over $2 trillion on food. According to the AARP, if you add up the cost of all that family caregiving, it's over $1 trillion, which is larger than our defense budget. The National Academies has a smaller estimate for just older adult caregiving by families. It's about 500 million, which is larger than what we spend on formal long-term care services, entertainment, apparel, consumer electronics. So we get long-term care in this country on the backs of families, and when individuals need formal long-term care services, it's Medicaid or largely paying privately. So our system was going along, and really COVID lifted the veil on our long-term care system. One of my colleagues called it a crisis on top of a crisis. The short-term crisis was obviously the pandemic. It was COVID. We had a number of deaths of individuals in long-term care settings. We had long-term care recipients being isolated, high rates of loneliness. We did a piece showing nursing home staff was the most dangerous job in America during the pandemic, with death rates exceeding any other profession in the US. We had many staff leaving the profession, and obviously we had declining admissions and occupancy. So that's the short-term crisis. The longer-term crisis is what's below, and that's our system. We largely rely on Medicaid. Medicaid is not a very generous payer of long-term care services. We often have poor quality of care, inadequate staffing, low pay. Jasmine's going to talk later in this session about disparities. All too often, our nursing homes are these big institutional buildings that look like hospitals that don't really deliver person-centered care. We have a heavily regulated model that often isn't very effective in meeting the needs of our residents. And then we have a lack of quality and financial transparency. It's hard to tell what level of quality is being delivered in these settings, and how the dollars are being spent. And finally, we have large shares of for-profit owners, some of whom are private equity groups and real estate investment trusts. It's really hard sometimes to follow the money. So how do we fix all of these this longer standing crisis? And I would argue, I wrote a piece in Nature Aging a couple of years ago where I said we can't think about this as let's abolish nursing homes and get everybody out in the community. For older adults, we're probably always going to need nursing homes. Even those countries that were at the top of the spending list, like the Netherlands and Sweden and Norway, they have nursing homes. They just have much better nursing homes than we do. They're much smaller. They're much more person-centered. So I would argue we need to do 4 things. And these are just the beginning of a list, but I think these are 4 core issues. First, we need to invest in home and community-based services. Second, we need to shift to smaller home, resident-directed nursing homes. We need to do away with these large institutional facilities. We need to invest in workforce across the board in all settings in terms of better working conditions, pay, and benefits. And then finally, we need to do a better job of integrating clinical care in these settings. So let me work through each of these quickly in turn. So first, investing in Medicaid home and community-based services. I want to tell this in 3 pictures. The first is in the upper left, once again, great data from Kaiser, showing that in 1995, we spent 18 cents out of every Medicaid dollar that we spent on long-term care went towards home and community-based care. That's up to 59 cents today. So we've made incredible strides in rebalancing our long-term care system. This rebalancing, however, has not been uniform. You can see that in the upper right in the map there. The darker shades are those states that have more heavily invested in home and community-based care. The lighter shaded states are those that are lagging behind. And then in the bottom, you can see we have 700,000 individuals, and there's probably a lot more individuals who aren't on waiting lists or on interest lists that need and would benefit from home and community-based services. So there's a lot of excess demand for these services. How do we fix this? We need more funding. There was talk following the pandemic of $400 billion for home and community-based services. Those dollars never came to fruition. We definitely need to redouble our efforts in terms of additional funding. I would also argue we need more resources in helping older adults to navigate and access these services. I wrote a piece in The Hill with Ann Tumlinson and Bob Kramer about our system basically being a road to nowhere. We don't have enough dollars in home and community-based settings, and we don't really know how to navigate the card to the services that are there. So a lot of work left to be done with HCBS. Transitioning to nursing homes, I put up some pictures here of the greenhouse model, which is one of the small home models that's out there. If you can believe it, all of these pictures are of greenhouse models around the country. In the upper left there, that's not just a neighborhood, that's a nursing home, if you can believe it. We have greenhouses, these small home models where 8 to 12 older adults are living in a community in rural, suburban, and urban areas. And you can see in the middle panel there and the upper right, the table in the kitchen where older adults in a greenhouse model eat their meals together. They have their own rooms where if you want to enter their room, you knock on the door and it's their space. And then in the bottom right, individuals navigating. Lots of data suggesting there's a higher quality of life. This is what residents really want. They want a more home-like setting, a smaller setting where it really feels like they're not living in an institution under someone else's rules. This is associated with a higher quality of life. We've done some work on greenhouse suggesting there's also a better quality of care and lower Medicare spending. There's some savings there. Greenhouse is the largest small home model, but it's not the only one. There's certainly other models out there. We have very few of these homes. We have 15,000 nursing homes in the US. Very few, a couple hundred might be considered these small home models. So a lot of work left to do to transform this. If you can believe it, HUD, Housing and Urban Development, does back a lot of the loans, the capital that flows into nursing homes. We hear a lot about private equity. HUD is actually the big backer of a lot of these loans. I won't get into the weeds here on our recommendations, but we wrote a piece earlier this summer suggesting HUD is falling short right now in terms of how it might encourage greater innovation in terms of these small home models, private rooms. There's all sorts of innovations that HUD could really encourage. However, they haven't, and there's work there to be done. Transitioning then to workforce, we need workers across the board. This was true before the pandemic. These are just nursing home staffing data, and we did a paper in 2019 showing that most nursing homes are below what CMS would expect based on their acuity adjusted levels. And you can see we need a lot more staff to encourage safe and high quality care. We lost a lot of staff during the pandemic. Over 400,000 workers left. We've seen an uptick here, and so we're almost back. We're about 84,000 workers below what we were pre-pandemic. So we need to continue to grow this workforce. How have nursing homes and other long-term care settings maintain their staffing? They've done it by foreign-born staff. So we did a paper, Kate June and I, showing that although we lost a lot of native-born workers in nursing homes, foreign-born workers actually largely stayed in the sector. And then this won't surprise anyone. In another piece we did earlier this year, we had to turn to a lot of contract and agency staff. So we didn't have permanent staff, which would be associated with a higher quality of care. And so many nursing homes had to go out and get those contract workers. How do we fix this? I wrote a piece in 2021 in Politico. Nursing homes need fixing. Here's where to start. This is always, to me, like 2/3 of all spending is on labor. This is where you need to actually make this investment. It's better pay and benefits. We're going through a minimum staffing standard right now at the federal level that's been introduced and currently in place. So the administration actually listened to that idea. We need higher reimbursement rates and accountability that those rates are going to be directed towards staff. We need to provide career advancement for workers, a better place to work, a better working environment, and then obviously we need to increase immigration. And these aren't either or. We need to both increase pay and benefits and immigration and make sure this is a job worth having. Finally, this issue of investment in clinical care and long-term care settings. It's not just that we have an underinvestment in long-term care, it's that we have a fragmented reimbursement system where you can see there in the middle, most individuals in post-acute and long-term care settings, their care might be covered by Medicaid, but Medicare is covering all of their healthcare services, the physician services they're receiving, anytime they go to the emergency department or the hospital, and then potentially, Medicaid and Medicare are bumping up against each other, and we see this a lot in terms of the quality of the clinical care that long-term care recipients are receiving. The canonical example of this issue is really clinical coverage in nursing homes, especially off hours. If you go in a nursing home in the evening or the weekend, there's not a lot of clinicians on site. This can result in trips to the emergency room where if there's a call, a resident short of breath with a fever, you call her physician. This physician could come by and see them, could kind of work over the phone, but in all instances, this physician is often transferring the resident to the emergency room, and then they're getting admitted to the hospital. One solution here, and there's a lot of them, nurse practitioners, more clinicians on site, RNs, et cetera. One idea is the use of telemedicine, and telemedicine, obviously, rather than making that call to the individual's physician, now you're looking eye to eye with the physician. There's an RN by the bedside there, helping facilitate a two-way video conference. The idea is this kind of intimacy through a video conferencing can prevent some costly transfers. And at least pre-pandemic, this wasn't covered. And so Medicare only covered this in rural areas. If you're an urban nursing home, you would have to pay for this yourself. So we actually partnered with a nursing home chain here in Massachusetts, and they actually rolled out a randomized telemedicine intervention. We found amazing results by having that telemedicine intervention off hours rather than the traditional call to the covering physician. We prevented quite a few hospitalizations, which generated $100,000 per nursing home annually in Medicare savings, whereas the telemedicine service costs about $30,000. You don't need a degree in economics to figure out, hey, that's cost effective. That's really exciting. So I was out trumpeting this result, presenting it at meetings. Meanwhile, the nursing home was sort of stewing on this. They said, wait a second, we're making the investment here, $30,000 a year, $100,000 savings to Medicare. They ended up discontinuing the program shortly after we generated our results. They didn't want to pay anymore to save Medicare money. That's really the disconnect that we're dealing with here in this area with this fragmented coverage. The nursing home is receiving Medicaid dollars or private pay dollars, but Medicare is the one that's saving money when hospitals are prevented, and that's obviously any kind of investment here in clinical care, given that wrong pocket problem, if you will, is going to be limited and unsustainable. How do we solve that? There are some models out there, and I'm going to throw alphabet soup now at you, whether it's the PACE program, a lot of the different special needs plans or SNPs. There was also the Financial Alignment Initiative for duals. Lots of models out there. And these models actually account for a pretty small share overall of all individuals who are dually eligible in long-term care settings. They're still just a drop in the bucket. I wrote a piece in NIHCM last year where I argued that there's ways that we could actually fix this, whether we passively enroll individuals into these models, improve the alignment between Medicare and Medicaid, and convert some of the models that don't work very well, like a traditional dual eligible special needs plan, to one that's fully integrated. We need to improve our data and measures that evaluate these programs, and we need to move towards a more unified approach that it's not that alphabet soup in terms of that list. So to sum up here, there's a lot of work left to be done to meet the needs of aging Americans. I would argue 4 important areas are: 1, we need to grow home and community-based services; 2, we need to transform our nursing homes that are out there; 3, we need to invest in the workforce across all of these settings; and finally, regardless of setting, we need to invest in clinical care. I'll stop there and say thank you and look forward to questions and comments.